Welcome to ANZICS Meet the Expert podcast series, that is Intensive Talk. In this podcast series, we meet with experts around the globe to discuss various challenges that we are facing as a community and understand how experts look at these problems. Hi, my name is Swapnil. I work as intensive care specialist in Sydney, and it's my honor and privilege to welcome Professor Dale Needham from John Hopkins. Professor Dale Needham is a professor of medicine at John Hopkins University School of Medicine, and he serves as the medical director of the critical care physical medicine and rehab program. Also, he's the director of outcomes after the critical illness and surgery group at John Hopkins. So welcome, Prof.
Thank you so much. I'm happy to be here.
So, Prof, obviously we are in the midst of COVID-19 pandemic. In John Hopkins, you've been doing great work in your ICU. So can you please walk us through your experience with COVID-19, please?
Sure. So I want to give a little bit of context. So as of this morning, today is Wednesday, May 20th, along with Chicago and Los Angeles, the greater Baltimore, Washington area is one of 3 current hotspots for COVID in the United States. This hotspot designation really means that at this stage of the pandemic, the incidence of COVID has sort of plateaued in these 3 places, as opposed to elsewhere in the country where it's actually declining. So although we're a hotspot, the incidence doesn't appear to be rapidly increasing anymore. We were very lucky in the Baltimore, Washington area that we had the advantages of observing other areas, particularly New York City, that had an earlier peak to the pandemic, as well as a much larger incidence than we've had. So we had the ability to watch and learn from them and to give us time to prepare our own responses, and had lots of ability to have contact with colleagues there to help us. So I think to put some of this in context, initially as the pandemic started in our region of the United States, there was a plan to move all patients experiencing COVID-19 from the 4 other Johns Hopkins hospitals that are affiliated to our Johns Hopkins Hospital, which is a 1,000-bed a hospital that has a brand new critical care tower. And initially that's what happened. And we got a lot of patients relatively quickly, especially as they were being transferred in from our other hospitals. With the advantage of our relatively new infrastructure, we were able to make entire hospital units negative pressure. So our ICUs are all individual patient rooms, but not only was the patient room negative pressure, the entire unit was negative pressure. So meaning the hallways, the nursing workstation was negative pressure, so that when one entered the ICU, they would put on their personal protective equipment or PPE before actually entering the unit itself. There were so many cases that eventually each of the other Johns Hopkins affiliated hospitals needed to care for patients themselves. But by initially transferring them all to the Johns Hopkins Hospital, it again allowed the other hospitals to build infrastructure, to do physical modifications that were necessary, and to have staff prepared for the surge. So at our peak at the Johns Hopkins Hospital, we had 7 hospital units that were dedicated to the care of critically ill COVID-19 patients. And in most of those ICU patients had ARDS and severe ARDS. And these patients were frequently prone, some of them were paralyzed, and very, very sick. Given the high number of patients that were being proned, some of the intensive care units, and some of these weren't intensive care units to start with. So for instance, one of the COVID ICUs was an intermediate care unit that then was upgraded to be ICU level of care. Another one of the units was a pediatric ICU where half of the beds then became dedicated exclusively to adult COVID care. So one of the things that happened is some of these units weren't so familiar with proning. So for example, a proning team was created to make it easier for ICUs to prone and to supinate patients. So that's also one thing that had happened. And having to surge to have 7 intensive care units for COVID created many important staffing issues. So for example, when I was recently on service, the ICU physician trainees or residents working in the ICU included a radiology resident, and a dermatology resident who normally would not be doing clinical care in the intensive care unit. Also, in Canada and the United States, mechanical ventilation care are done by respiratory therapists, so a separate type of clinician rather than by, for example, physiotherapists. And with the huge surge in the number of ventilators, we needed to have more people functioning in the respiratory care role. So there would be physiotherapists that were trained to provide ventilator care. There were also nurse anesthetists that were trained, as well as anesthesiology residents or physician trainees that were trained to have those roles so that there were adequate staff to set up and take down ventilators, to provide meter dose inhalers, to make ventilator changes, to do driving pressure evaluations and these sorts of things. Also, of course, we also had shortages of ICU nurses to staff now 7 COVID ICUs, and many other strategies were done to have additional nurses partner with our traditional ICU nurses in delivering critical care. We also needed, with all of these ICUs, to have safety officers that helped prevent breaching the negative pressure areas, to help with donning and doffing the personal protective equipment, and many other staff in areas of the hospital that had become closed down. For example, the operating rooms or operating theaters, the outpatient areas, much of pediatrics became redeployed as safety officers that were a critical part of our response. So I think that many of these examples that I have speak to the need for teamwork, the need for planning, the need for everybody to draw together. So those were some highlights of the ongoing COVID experience at the Johns Hopkins Hospital and in the greater Baltimore, Washington area.
So it seems like you have done enormous amount of work, and looks like there are a lot of challenges in terms of logistics, but also there are a lot of challenges in terms of dealing with the clinical side of COVID-19. Now, you touched upon the severity of these patients, and you mentioned that a lot of patients were actually suffered from severe ARDS. And there was a lot of discussion after Luciano Gattinoni published this paper on L phenotype and H phenotype. So what was your experience with lung mechanics of these patients with COVID-19?
Sure. My own experience, I think, is consistent with some publications that have come out with actual data on lung mechanics. My anecdotal experience, which I do think is consistent, is that our patients with ARDS really had a range of lung compliance, for instance, that were consistent with other large-scale studies that have been done, large-scale studies of ARDS that demonstrated a range of compliance. I think the most important take-home message from COVID, in my experience, is just the sheer number. You know, the way that I often put that in perspective is most of the patients with severe ARDS at the Johns Hopkins Hospital would be cared for in our medical intensive care unit that has 24 beds for medical critical illness. And, you know, we might have, in terms of severe ARDS, maybe 2 or 3 patients at a time that are quite sick with ARDS. But during COVID, as I've alluded to, we now had 7 intensive care units with many, many patients that had severe ARDS. So I think that was the bigger issue with COVID, rather than us seeing some novel differences in lung mechanics based on my experience and my read of the publications that have come out very recently that actually provided lung mechanic data. I do think it's important to maybe note, while we're talking about ventilatory support, is that I didn't talk about earlier, is that we routinely do use high flow nasal cannula in the care of our patients with COVID at the Johns Hopkins Hospital, but we weren't traditionally using non-invasive ventilation or continuous positive airway pressure unless there was a specific pre-COVID indication for that, you know, a patient with obstructive sleep apnea, for instance. I think also there's probably a couple of other trends that are worth noting. I think early in the pandemic, we were taking a more conservative approach, meaning intubating patients earlier when they had COVID. And I think over time, as we got greater experience with intubating large numbers of patients and donning and doffing PPE and having airway teams get more experience, we took a more traditional approach that didn't intubate patients as early. And that may also contribute to what we see in terms of lung mechanics, is the timing at which patients are placed on mechanical ventilators. And then I also think similarly, earlier in the pandemic, we had a later approach to doing tracheostomies, whether it's in the OR or at the bedside. And then as, again, we got greater experience in the use of tracheostomy procedures, really now in the current time reflects our traditional practice from before COVID in terms of timing and indications. But of course, the PPE is quite different during COVID as compared to prior.
Thanks, Prof. And I think you mentioned a lot of key points in that answer. And I just want to unpack a few of those issues. So in terms of numbers, actual numbers, how many patients you think you have kind of treated so far, and how many percentage of that population has suffered from severe ARDS, required mechanical ventilation, and required tracheostomy? Do you have any kind of rough numbers with you?
Yeah, I don't have any hard numbers to give you. There are other people on our team that are clearly tracking these things. We're very fortunate to have a Johns Hopkins registry of every patient with COVID, and there are other people who are dedicated to specifically keeping track of those things. I can give you a couple of pieces of data that might help. I, for example, one day just counted the number of critically ill patients, so patients in an intensive care unit with COVID. And on a single day, a little while ago, we had 80 patients, for instance. Also, a couple of weeks ago, I looked at the number of patients that we have treated with COVID in the Johns Hopkins Hospital. These are inpatients. And as of a week or two ago, I think that was around 1,200 patients that had been in the Johns Hopkins Hospital with COVID. So those are the most statistics that I can give. I don't have the number of patients that have had tracheostomies, and in part because it's really over the last couple of weeks that we've moved from a more conservative or delayed approach to a more traditional approach. So the number of patients with tracheostomies is ramping up quite quickly, because we've had patients when we were more delayed with this that may have been on a ventilator for 3 or 4 weeks, not been liberated from the ventilator. And now that we're back to more traditional approaches, these patients are all moving on to tracheostomy. So I think our tracheostomy service have been quite busy. I do know, because the number is quite small, that we've had very few patients that we've used ECMO for. For the most part, our patients have been managed with lung protective ventilation, prone positioning, sometimes neuromuscular blocker infusions or boluses, and sometimes inhaled nitric oxide, but much less with ECMO in our center.
Thanks, Prof. And I still can't imagine how you guys gone through that phase, because in a way we are very lucky in Australia here. We didn't see more than 100 patients in the entire New South Wales. So I guess it just, even hearing that number kind of scares me. But I guess you guys were very well prepared, and you had the whole ICUs were negative pressure ICUs, which is kind of amazing. Now, especially talking about your research, like you have extensive track record of research on rehab in ICU. And as you mentioned, probably the most of the COVID-19 patients are staying in ICU probably more than 2 weeks. And that's kind of a consistent data from Italy, UK, that these patients, if they survive, they stay at least 2 to 3 weeks in ICU. How did COVID-19 affect that aspect of patient care in Johns Hopkins?
Sure. So I'll tackle that question in a few ways. So the intensive care unit that I work in is the medical intensive care unit. And for almost 15 years, we've had a critical care physical medicine rehabilitation program that's funded by the hospital that I'm the medical director for. And when the pandemic first started, there was lots of uncertainty. There was lots of uncertainty around the world. The number of emails that I was receiving from people from around the world, like, how are you tackling ICU rehabilitation? People emailing saying, at our hospital, PTs are not considered essential workers. They're not given personal protective equipment. We don't deliver rehabilitation in our intensive care unit anymore. There's a whole range of reactions. And I think every hospital experienced that. I think we experienced uncertainty and stress, and what is the proper kind of personal protective equipment. So there was a lot of uncertainty initially. There were important relative shortages of personal protective equipment, meaning that everybody that needed it had personal protective equipment, but there was rationing of it. We didn't want personal protective equipment to be inappropriately discarded or somebody to run out of personal protective equipment. So we're very careful with the use of it. So it took a little bit of time, a matter of a few days before we were clear that there was adequate personal protective equipment for all members of our rehabilitation team, and that they were trained and comfortable with using personal protective equipment. We needed the doctors and nurses in the ICU to also feel comfortable that these patients, despite their severe critical illness, were going to resume mobilization just as we had done in the pre-COVID era. And that took some time for people to get used to, because now we would have an entire intensive care unit full of very, very sick patients, rather than just a smaller number of patients and some patients with less severity of illness. So everybody is stressed and busy, and it took time to work through those things. But because we had an existing culture of ICU rehabilitation, because our doctors and nurses were used to this, because we had highly skilled OTs, PTs, speech language pathologists, psychologists that were used to dealing with critically ill patients, we had the infrastructure and the culture to make this happen. It just required a lot more communication than normal. And my role as a medical director meant that I needed to be reaching out to the physician director of the ICU, the nursing director, the leaders in physical medicine rehabilitation, the frontline doctors, nurses, and rehab staff, for us to move together as a team, with this being the focus of what I was focused on. You know, with this large of a pandemic, among our critical care physicians and faculty, people all need to take different roles. And what I thought of my role, and what is my role, is to put this front and center, and to spend my time and energy thinking about how are we going to not just have patients survive, but optimize their recovery from a physical, cognitive, and psychological perspective, using the resources of our program. So we did get through this. We did have adequate PPE. We did have an infection control plan. And we went back within a relatively short time of resuming our regular physical medicine rehab program in my medical intensive care unit. We did have some innovation, because sometimes in the very early stages of critical illness, when patients are severely critically ill and maybe getting neuromuscular blocker infusions and certainly deep sedation, the role of occupational therapy for splinting, in our ICU, occupational therapists are the ones that assess patients for splinting. Some of that could be done through telehealth. So the OT did not need to necessarily don PPE, could review the chart, could talk with the bedside nurse and make a recommendation. And then if a PT was already treating that patient, they could visually inspect the splints and get back to the occupational therapist. So we did have some innovation. And also, as another example of that, we have a rehabilitation psychologist who routinely sees patients in our medical intensive care unit. And Dr. Hosey did a combination of telehealth as well as in-person visits with patients, and kind of worked through that as well as an adaptation to the pandemic. In terms of our speech language pathologists, their fiber optic evaluation of swallowing is something that's currently on hold, but we are hoping that we can work through carefully the infectious and aerosol generating risks of that, to find a safe way to hopefully resume fiber optic swallowing studies, just as we've resumed doing tracheostomies as well. So that one is still a work in progress, and our SLPs haven't restarted doing fiber optic swallowing evaluations. I think also what's quite important, given that we had this large infrastructure and experience, and now had many ICUs with patients with COVID, we took sort of the MICU approach that we'd created, and with the help of redeployed therapists and redeployed physiatrists, physical medicine and rehabilitation physicians, we were able to spread that MICU approach more liberally to all of the other ICUs, including ICUs that normally weren't functioning as ICUs, including hospital units that weren't functioning as ICUs, such as our intermediate care unit that was upgraded to an adult ICU, our pediatric ICU that was changed over to providing adult COVID care. We were able to take these approaches that we had used, along with redeployed OTs and PTs and redeployed physiatrists, to move that off across all of our COVID ICUs. And then I think also what's important is the care of patients after their critical illness, with a lot of great thought from our physiatrists, our PT, OT, and speech leaders, they were able to create new pathways for rehabilitation for many of our patients who had acute COVID disease or had critical illness and had begun to recover and had left the ICU. So importantly, they created different pathways and they were able to deliver larger doses of rehabilitation than had traditionally been applied, in part because we knew that our access to rehabilitation facilities, to inpatient rehabilitation facilities, was going to be dramatically limited in the early stages of the COVID pandemic. So we needed to do more rehabilitation in place. We needed to increase the doses of rehabilitation that appropriate patients were receiving outside of the ICU as well as inside of the ICU. We wanted to see the gains that had been done in the ICU continue. And in fact, we even had an approach where the traditional level of acute inpatient rehabilitation therapy, that dose of therapy, would be delivered to patients that weren't in an acute inpatient rehabilitation facility. If they looked like they would benefit from that, we created pathways and staffing to allow that level of rehabilitation to happen outside of the kind of traditional acute inpatient rehabilitation facility. So many of our physical medicine rehabilitation leaders played an incredibly important role in taking this sort of NICU rehab approach and ensuring that all COVID patients throughout the hospital were able to benefit from that.
That's amazing. And I think I can only say congratulations to you and the entire team for showing us that rehab in ICU is feasible even in COVID-19 pandemic, because I share the same concerns that you mentioned initially, that a lot of physiotherapists in our ICUs or in Australia, they were expressing concerns with donning and doffing and getting in contact with patients. And there was that kind of concern providing the routine care for these patients. That's just amazing. One of the things that I heard from experience from Italian intensivists or UK intensivists is that the prolonged length of stay in ICU and causing the bed block, and that hampers the routine care to other patients or even new admissions to ICU with COVID-19. How did you deal with that challenge in John Hopkins?
So we dealt with that challenge by being able to create more ICU beds to be used for COVID patients. And that also occurred in the setting of there being less patients presenting to hospital for other reasons, and some of which may not be appropriate. There may be some patients that were at home and were scared to come into the emergency department and didn't. So sadly, there may have been some cases of that. I don't have any data around that, but the media report on that. So perhaps that happened. But also, of course, like many intensive care or many hospitals in the United States, elective surgery was completely shut down. So that gave us traditional ICU beds that were dedicated to post-surgical patients, allowed those beds to be redirected to COVID critical care. So we still haven't restarted elective surgeries, and that's one way that we've created more critical care beds that could be available for critically ill patients. We have opened up urgent surgeries such as neurosurgery and transplants have been opened up and are now restarted and very, very busy, but our more elective surgeries have not yet restarted. And that allowed us to have more critical care beds available. We also have recently had some intermediate care units be prepared to take patients that have tracheostomy and even patients that have tracheostomy that may have stable ventilator settings to help decant patients from the acute ICUs. And then I think also one thing that's just important to note, you've highlighted the longer lengths of stay, and I think that as part and parcel of that, we have to understand the very high attention to detail that's used in caring for those patients every day. We want them to get better as quickly as possible. And in patients with severe single organ failure, severe ARDS without other organ failure, we need exquisite attention to detail in every aspect of care to try to prevent there being secondary complications that of course would harm patients and prolong their length of stay. So that exquisite attention and thinking about checklists and making sure that all of the things we did in the pre-COVID era are now continued in the COVID era and being done across every single patient. I must say that that the cognitive load among all of our staff, and particularly I can speak most to me, is so much higher. When every single one of your patients is so incredibly sick, you need to think and concentrate so much. You have to hang on every single detail because they are important for our patients. There aren't any patients in our ICU that are not really, really sick. So listening and hearing and communicating is very important. And it's also fairly complicated when our workflow has changed with COVID, and many of us are wearing PAPRs, where hearing is more difficult because we've got the hood on with air blowing around our ears. That makes things harder to hear. That's a distraction and a stressor. But having those checks and balances in place to make sure that we're not missing anything for any patient, I think is important to also reducing length of stay and optimizing patients' outcome.
Thanks, Prof. And one of the known complication of prolonged length of ICU stay is development of critical illness, polymyon neuropathy. And is it the same pattern that you're seeing with COVID-19, or are there any kind of particular differences between recovering COVID-19 patient versus other patients with ARDS?
Yeah, that's a good question, and I'm not sure that it's one that anybody has the answer to at this stage. Certainly at our hospital, I know it's suspected at most hospitals, we're not doing nerve conduction studies and electromyography. So to really understand what's happening with the nerve and muscle, because of infection complications, those tests simply are not being done. So I don't think we've got the same level of detail as we would before COVID. I do think that we are seeing ICU-acquired weakness. That's not a surprise in patients, especially if they've been prone, deeply sedated, and given neuromuscular blockers. We are seeing shoulder subluxations, in part because patients may be prolonged for long periods of time and have muscle wasting that would contribute to that. Although I think one interesting thing that we're seeing among some patients is with COVID, and with our referral patterns that are happening, we're having some patients come to our ICU that don't have comorbid disease. Often our ICU, it's a quaternary care hospital, admits patients who have much comorbidity and lots of complexities, and certainly from the surrounding local Baltimore area. But as we're having patients referred in from our other affiliated hospitals, and because of COVID, we're seeing some patients referred that have very little comorbidity. And some of those patients, surprisingly, despite being very weak as they're being liberated from the ventilator and during the early stages of the rehabilitation, some of them had been getting very stronger very quickly. Some of these patients, even in the ICU setting, were getting 2 sessions per day from a physiotherapist, or 1 from a physiotherapist and 1 from an occupational therapist, and they were seeing gains within the same day in the recovery of strength and function of patients. So we have had a smaller cohort of patients that are making surprisingly fast recoveries, in part because they may not be some of our traditional patients that normally are cared for in our ICU, because of the referral pattern and because it's severe COVID that has ended up a previously healthy patient getting into our intensive care unit. So that would be a couple of my observations there. I certainly think it would be very nice, maybe in later stages of recovery where there's less infectious concerns and patients are COVID negative, to see if studies will come out that do EMG nerve conduction studies to help understand the pathophysiology of nerves and muscles.
That's great. Another aspect to whole pandemic was how to rationalize resources. And there was a lot of talk about age being the prognostication factor and limiting the care to anybody who is more than 80-year-old or 70-year-old, depending upon the number of resources that are available. And I think that Douglas White from Pittsburgh suggested the framework that was widely adopted to US in terms of rationing of the care. What kind of frameworks did you use in John Hopkins to kind of allocate resources to these patients?
So we've been very fortunate in the greater Baltimore, Washington area that we were able to expand our available resources to meet the demand. We have not ever at my hospital been in a situation where the demand exceeded our resources. As I talked about, we were able to redeploy staff, We had enough ventilators. We had enough dialysis machines. We had enough staff, importantly. And I talked earlier about how we trained to ensure that we had staff to deliver services that were required. So we didn't have to make those tough allocation decisions that you've alluded to. But at the same time, in the earlier stages of the pandemic, we were making plans. Again, not me. There are other people on our team that played very important roles in giving input into allocation strategies should they actually be needed, and working at the state level. And that was an area of research that people from Johns Hopkins, particularly Dr. Lee Doherty, for instance, had been working on for many, many years. So that was able to be revived and updated to COVID-19, but there was never a formal statewide plan that was made publicly available, and we never had the demand exceed our resources. So we didn't have an allocation plan at our hospital or a formal plan in our state, despite what you may have heard elsewhere from media, for example, in the United States.
Yeah, it's good to hear that you guys were very well prepared and you didn't have that problem which rest of the other countries like Italy faced or some of the other states in US faced. So I think, again, well done. Now,
I think there are many people that get credit for the planning that went into this. You know, I should get none of the credit for this. I'm simply a spokesperson, but there are many people that have thought very hard about this and made plans far in advance and these sorts of things. You know, even when our new critical care tower was built a few years ago, you know, there are now kudos back to the plant people at our hospital that wanted to make sure when planning this new building that we could have entire units that become negative pressure in a relatively easy way. So there were many things that people had spent lots of time thinking about that really helped us so far in the pandemic.
Absolutely. It's a great teamwork. One of the news that we are hearing now, US has decided to open the lockdown despite relatively high number of cases. Are you concerned, and how are you preparing for the second wave of COVID-19 if there is one?
Sure. I think everybody's very, very concerned. So where I live, where Johns Hopkins is in Baltimore, it's within the state of Maryland, and Maryland is beginning to ease the lockdown, but the city of Baltimore and the county of Baltimore have not eased the lockdown. So despite other places in the state easing it, it's still lockdown in the city and the surrounding county. I think in terms of the planning of our leadership, our critical care leadership, we plan to still have ICUs available and to recognize that there's going to be a need for this for a while to come. So as I said, we haven't restarted elective surgery as of today, at least. And we are continuing to think about staffing patterns to allow a sustained response to COVID-19. So we haven't backed down our preparations because there is fear that there may be a second wave. And I think while we're still in lockdown, we can probably learn from other areas in the United States that are being more liberal and watching the trends. Of course, you know, some of the lockdowns really have just happened over the past, or the reverse of lockdowns really over the past few days, and we'll need to probably wait a couple of weeks at least to begin to see the impact of that on the pandemic and whether there'll be another surge or not. As I said, we are one of 3 hotspots in the United States in that our counts have plateaued rather than had large drops. So we're still in a heightened state here at the Johns Hopkins Hospital.
Okay, and I think that's a kind of nice segue to the next question, that impact of COVID-19 on the staff morale or staff well-being. So, or what are the strategies that you implemented at Johns Hopkins to deal with staff morale?
Sure. I think that we absolutely have to recognize, I talked about the cognitive load and the concentration that's required in these very sick patients. And also, I haven't talked much about how throughout the United States, pretty much family members are not permitted to enter the hospital unless there's particular circumstances. So there's also a stressor of not having the family members at the bedside. And there's stressors in terms of changes in communication patterns as a result of that. So that's another stressor on top of the cognitive load. So also in most hospitals in the United States, their family members are not allowed to enter the hospital. And that creates a new stressor in that family members aren't there to help care for their loved ones. It also raises new challenges with communicating to family members of very sick patients when you're not doing it as face-to-face communication. So I think that also provides a stress. I think the duration of the pandemic, and without the certainty of knowing when it's going to get better, adds a stressor. And then we need to recognize that schools are closed, and many staff are going from their busy, stressful day job home to providing homeschooling for their children. So the workday has just got tremendously longer. You know, one of our very strong ICU nurses on Sunday when I was in the ICU was talking to me and said, like, she just feels exhausted because she comes home from work and then she does homeschooling and she's not getting to bed until midnight. And we don't know if school will even restart with the new school year. Here, the entire school year has been closed. So we know that for several more weeks, homeschooling will continue. So these are many stressors. I think in terms that are things that are happening, for example, my division, the Division of Pulmonary and Critical Care Medicine, this concept of wellness has been on our radar screen since the beginning of the pandemic. So in the early stages of the pandemic, information sharing is tremendously important. And we had 3 meetings a week, 3 faculty meetings per week dedicated to COVID, as well as educational sessions on top of that. And in our Division of Pulmonary and Critical Care Medicine at the Johns Hopkins University, we actually have a number of psychologists as part of our division. They're primary appointments in pulmonary and critical care. And they do fundamental research around adherence, for instance, and around psychological outcomes. And they stepped up and really helped our division lead a focus on wellness. We have 3 support groups every week. We have one for faculty and fellows that are delivered virtually over Zoom. We have one that's for fellows alone. We also have one for hospital or divisional staff and family members and friends. So I think that's very important. The hospital, for example, has mindfulness programs that are open to anyone. We have app-based programs for relaxation. So I think there are many things. Also, our hospital is fortunate to provide, our hospital and university, to provide before COVID, access to counselors and mental health help for anyone at any time, 24 hours a day, 7 days a week. And I think I'm going to suspect that that's being accessed more often, although I don't have any data around that. So I think we are doing many things proactively. And I think the fact that it was proactively planned is really important. But also, for example, the psychologists who are part of our division are telling us that with these kind of natural disasters, there are different waves that individuals go through, you know, where they feel like they're scared at first, and then they feel like things are under control, but then they reach exhaustion. So they're helping us understand what we might be going through and helping us prepare for that. So there are many things that are underfoot, but this is a very challenging and difficult time.
Yeah, that's just amazing. I think having a psychologist in the department is very useful resource. And again, it's a lot about anticipation and planning and preparation. So again, well done. One of the kind of controversial area amongst during this pandemic is novel treatments. And there's a lot of talk about initially about the hydroxychloroquine, or still there is a talk about hydroxychloroquine. Then remdesivir came on the horizon, and a couple of antiretrovirals came and gone. Have you tried any of the novel treatments in these patients, and what's your experience so far with these therapies?
Sure. So you won't see me using experimental therapies outside of a randomized trial. I'm not the kind of person that says, oh, let's give tocilizumab a try. I think that the best care starts with meticulously adhering to evidence-based practices for ARDS and using additional therapies that we're already familiar with. So although we, after the ROSE randomized trial from the PEDAL network, we may not be routinely using neuromuscular blocker infusions, of course, anymore, but that is a therapy that we're familiar with. We do have a feeling for when the indications are for using that. So we would use lung protective ventilation, prone positioning, neuromuscular blocker boluses or infusions as needed. So I think that's very important, as well as preventing secondary complications. And secondary complications in my mind also include physical and cognitive and psychological complications, not just DVTs and stress ulcer prophylaxis. So we do need to focus very much on that. I do want to comment, as I've alluded to, many of my colleagues agree with me in that our approach is that we should be enrolling patients into randomized controlled trials if we want to be giving them unproven therapies. And I think that's tremendously important. I think without this, we're not going to have an idea of the safety profile of these medications in critically ill patients or the potential for benefit. So I think those things are very, very important. And I do acknowledge that when people are very scared and they have access to things like hydroxychloroquine that's not restricted, that it's very easy for some people to fall into a pattern that it's better to do something than to do nothing. But I don't agree with that approach. But I recognize that it is very easy to fall into that pattern. And we've had lots of thought and reflection among the attending physicians that work, for example, in our medical intensive care unit to think very carefully around these medications. We were having patients from other hospitals that were transferred to our hospital, for example, on hydroxychloroquine, and then had to make a decision. Do we continue it or stop it? Are we ever going to start that in our ICUs outside of a clinical trial? And it's important, I think, that we work together as a team, in part because typically we're providing 7 days of coverage and then a different attending physician comes on. So we want to have consistency in patient care and consistent messages to all the other people in the intensive care unit. So pretty much it's patients are getting the meticulous evidence-based care and then have access to clinical trials when they're eligible, so that they can carefully look at both the risks and the benefits. I think that one interesting thing to think about, though, is that research in this field isn't just about novel treatments. I think there are a lot of other things that we need to be researching and thinking about. I think that if we're going to think about anti-IL-6 medications and these kind of things, we need to very well characterize the inflammatory and the immunologic response. Some of that needs to be done very carefully so that we know what we should be talking about. And that's sort of an observational type of study that I think is very important to advancing the field. We also need to understand about aspects of post-intensive care syndrome. What are the physical, cognitive, and mental health interventions? Should we be doing anything differently in terms of our rehabilitation intervention? We also need to take the opportunity where family members traditionally are not in the intensive care unit. Can we design and evaluate novel ways of communicating with family members that help them deal with their own distress and potentially long-term distress that they may face? And then we also need to think about novel approaches to telehealth. Telehealth that's used in the ICU and after the ICU. How can we design and evaluate these things? I'll give you an interesting example. We needed ophthalmologic evaluation of one of my patients just a couple of days ago when I was in the intensive care unit. And believe it or not, that evaluation was appropriately completed through telehealth. The problem that the patient had they didn't need their pupil dilated and a look at their retina. So the ophthalmologist was able to provide that consultation through telehealth. So I think that's also a very important area that we should be looking at in terms of research for healthcare delivery, in addition to the novel therapies that all of us, of course, are very interested in.
Thanks, Prof. I think I'm very pleased to hear that you are also of the same opinion that don't prescribe any medications outside the context of a randomized controlled trial. And I think ANZICS took the same stand here, and we didn't give any drug on a compassionate basis, which was very important, I guess. And I guess as we go through this pandemic, we will probably gather more data and we will come to an understanding of all the mechanism, drugs, and pathophysiology of the disease. So I guess obviously the data is important, but doing it in a proper manner is also important. And I'm hoping that obviously there will be a lot of data on rehab side of things will come from John Hopkins in coming months, which will enlighten us about the whole recovery processes of this COVID-19 pandemic. Now,
yeah, I agree. I think that these are important things, and I think that academic physicians can play an important role, I think, in helping set standards and make decisions around these things that hopefully will will help improve our patients' recovery and help advance our understanding of the best way to care for these patients.
Absolutely. So what are your key messages to the broader critical care community from your learning from COVID-19 pandemic?
So I think based on my experience and reading as much of the literature as I can about others' experiences, I think that, again, we need to stick to the basics, stick to the evidence-based care that we have demonstrated improvement in patients' survival and function prior to COVID. Stick to that with meticulous attention to detail, because it's going to be tremendously hard to have this much attention to detail when there's this many sick patients. We need to be thinking about the proper approaches to not just to mechanical ventilation that I've really highlighted, but all the other aspects of care for which there's a large evidence base in terms of our approach to sedation and pain management and sleep and early rehabilitation. I think that the Society of Critical Care Medicine's PADIS guidelines, pain, agitation, sedation, delirium, immobility, and sleep guidelines, is tremendous as a blueprint for the things that we should be thinking about. And we need to be focused on how we can change the delivery of healthcare to optimize the delivery of this across a large number of patients in a very stressful situation, with some people working in the ICU that may not work in the ICU with patients that are this sick traditionally. So how can we create appropriate ways so that that standard of care can be consistently delivered to all of our patients that are so severely ill? I think that's the most important take-home message. I have not yet seen a novel approach that we need to deviate from our evidence approach for COVID-19 patients. That may come, but I have not seen randomized controlled trials yet that have given us these insights. But we do need to design and enroll patients into these trials so that we can take advantage of COVID-specific interventions if they're demonstrated to be beneficial.
Thanks, Prof. I think there are very key messages and a lot of important learnings from your experience at John Hopkins. I'm very glad that you could spare your valuable time today and share your valuable insights with us. Thank you very much.
Okay, thank you so much too. I really appreciate this opportunity of talking with, particularly with my colleagues in Australia and New Zealand and from around the world. Thank you so much.